There we are, thank you. So thanks for the introduction, Claire. Welcome everybody, thanks for attending. So I'm going to talk about the challenges of conducting research in an emergency or acute care setting, as Claire said. And I've worked as a clinician now in an emergency setting for about 25 years, but I've also worked as a researcher in the same setting for nearly 20 years. And as part of that, I've worked as a research physio, as a principal investigator, and as a chief investigator. So I've a fairly good sort of all-round appreciation of the challenges involved with conducting research in this setting. But more than that, I also have a reasonable understanding of how to overcome some of these challenges, mostly through trial and error and numerous sleepless nights, as Claire will confirm, as I often complain about. So this webinar is going to cover, firstly, what actually is an emergency or acute care setting. And then we'll look at some of the key challenges of conducting research in these settings, going through each of the different processes involved in research. And we'll do that through a number of different perspectives. So through mine, but also a service user, a couple of research nurses and a couple of principal investigators as well. And then, as Claire said, we'll have time for Q&A at the end. So as we know, any research study or trial comes with its own challenges, and we'd all agree with that. But in my opinion, I think the emergency care setting can make the research teams and the healthcare professionals involved feel like research is sometimes at best an uphill struggle, and at worst sometimes it feels like it's almost impossible. So what is an emergency or acute care setting? Well, emergency acute care refers to immediate and short-term treatment for any critical or life-threatening injury or illness or disease. And each of those three things can lead to severe pain or serious consequences if not addressed immediately. So as you can see on the slide, under the umbrella title of emergency acute care, there's already the potential for huge variation in the types of research studies that will be running within that setting. And they'll also be running in numerous different locations within the hospital. So it's not all just in one little bit in each hospital, that can be spread out throughout the hospital. One patient might be in a trial that starts in the back of an ambulance or even in their own home, compared to another that might be in an anaesthetic room being prepped for urgent surgery. So an emergency care researcher is already faced with a big challenge just in terms of the location of the patient and how the location is set up for conducting research. And you can see on the slide there, I've put all the different, or some of the different departments involved in emergency care research. There are also many different specialties that work within the emergency and acute care setting who are involved in research. So the obvious ones that spring to mind are the ones you see when we're watching our TV dramas or the documentaries now. So your patient who's been in a road traffic accident, a trauma patient, or somebody who's had a heart attack, so your medical patients. And then you'll have the patients who've perhaps chopped a limb off with a garden strimmer, so they would be your trauma patients. They're the ones we routinely think of as being involved in emergency and acute care research. But then there's also other groups of patients commonly seen in the emergency setting, and these are quite often the patients we have the most contact with. Are the ones who come back repeatedly and need ongoing care. So think about one large cohort we see are the patients with overwhelming social difficulties or challenges, and we used to describe those when I first started as the condition would be called acopious, the patient's just not coping with general life. And then there's the group of patients with mental ill health, and they may present with altogether different challenges for research teams. We've also got paediatric patients, we've also got older adults with complex needs such as multimorbidity and frailty. So what this brings with it is a huge amount of heterogeneity in the types of patients that we see. And with that, in turn, we'll get a very wide range of different types of research studies and trials running. And why is that important? Well, if you think about it, the clinicians or the healthcare professionals, not just the research teams working in these areas, the clinicians need a degree of understanding about each of the study and the processes involved with those. So as well, there is often the need for them to be involved with the identification of potential study patients, and such as screening. They might be needed to give out study documents or deliver different types of interventions. Thinking about it, these healthcare professionals rotate regularly, so they may be working in emergency care one week and then a week later they may be working in a totally different place. So we need to deliver a regular ongoing education programme as researchers, so everybody involved in the studies or trials they're running have an understanding of the research processes involved. So then let's think about the logistics of trying to do research in an emergency care setting. So pictures like these are seen almost on a daily basis now in our media now. We all know about overcrowding. Our emergency services are under significant unrelenting pressures, and whereas when I started it used to be quite seasonal, so we'd have winter pressures, we all know winter pressures as a term. It isn't seasonal anymore. This is the pressure, this is the reality of healthcare within an emergency and acute setting all the time throughout the year. Research staff will often find themselves outside the emergency care department, climbing into ambulances to recruit patients who might have been waiting for 10, 12 hours or more, even to be admitted to the ED, let alone to a hospital ward in a comfortable bed. Clinical staff don't feel that they've got time anymore to deliver even an acceptable level of care to patients, let alone consider taking on the additional tasks that we sometimes ask them to in relation to a research study or a trial. And that brings us quite nicely onto human factors involved with this. So as in all research work, we know that it takes time and resources to conduct our study processes. And we know that in times of great pressure and stress, there's often a negativity from the staff and the patients around research itself. So trying to get, as an example, trying to get clinical lead approval for a study can be the biggest challenge for even getting a study started. And for me as a chief investigator, we need the buy-in from our clinical leads in departments for the study to work, for it to be taken up by the staff. The staff we're asking to do this work, they don't want additional tasks to consider, especially ones that are considered to be novel or something that can't be delivered easily for them. Conversely, the positives though, for the staff, having research team members available can often also mean having an extra pair of hands, or it can mean that there's a drug or a device that may not have been available if the study wasn't running at the time. So that can work in our benefit as research staff, and that's something to really sort of think about when we're presenting ourselves to the clinicians within these environments. For patients, they've already been waiting hours to be seen. They may be tired, frightened, in pain, frustrated. I mean, they're more often than not very frustrated. One of my public research partners often describes when you chat to him about how he was unable to take on board any information following a nasty fall because he was so disorientated, and then everything he was told he promptly forgot, and he was on his own without a family member there at the time. As researchers, this often leads to our patients withdrawing consent or not replying to follow-up surveys because they don't even have any recollection of what they actually signed up to when we recruit early within emergency care. We do have low response rates in emergency care research, which is problematic for many of the trials and studies which I'm involved in. So attrition rates can be really high. Screening for potential patients can be difficult in emergency care research because quite often you'll be relying on triage staff, receptionists, trauma coordinators to alert you to a patient and to tell you that the patient is actually in the department and you need to come down. And they themselves are busy and completely overwhelmed with work at times. So they may actually be alerting many different research teams to patients coming in for different patient cohorts. Obviously, you've got the normal factors. They might be on annual leave or away from their desk when a potential patient's brought into the emergency department. Often the research teams within hospitals only work traditional office hours, but this doesn't fit with when certain patients present to the emergency department. So we all know the emergency department is at its busiest at weekends or the evenings, when our research staff may not be working if they only work office hours. So again, that's another challenge for us as researchers when we're designing our studies, something to consider. We also have challenges associated with screening for patients through the databases that we use and electronic records. And I'll talk about that in a little bit more detail when we talk about data collection. And then one of the biggest challenges, I think, for research teams working in the emergency setting is the consent process itself. So due to the nature of emergency or acute care, where we said at the beginning, it's where patients are critically ill, life-threateningly ill, a traditional consent model is obviously not always a feasible option. So it's not like recruiting a patient in a clinic or in a sort of primary care GP setting, for example. These patients often have a fluctuating level of capacity or consciousness. They may present in an acute psychotic episode or with physical trauma that would preclude them from signing a traditional consent form, written consent form. They may be in severe pain or frightened or frustrated, and all these things can impede the patient's capacity to understand the content of a participant information sheet. So within that, we need to think about how we present our patient information sheets. In some pre-hospital research, just as an example, the Paramedic 2 trial, the patient may actually be dead at the point of recruitment. So there are things that you wouldn't get in other areas that when you're trying to recruit to research that you need to consider. So I asked 2 research nurses who work in different emergency care settings. Rhys Thomas works in the ED and Jade Cole works in critical care in the Heath. I asked them to talk about the different consent processes and some of the key challenges from their own perspectives. And I recorded that. So let's have a little listen to what they say. And I'm hoping that the sound works okay on this video. So bear with me.
Yep, so most of the trials I do involve emergency deferred consent. So with those sorts of trials, they are trials where you need to give your treatment or your intervention really, really quickly within a really small time frame. And you're normally talking hours. So it's just not practical in those situations to speak to the participant, because 9 times out of 10, the patient population that you're studying is so unwell, they're likely to be unconscious or definitely lack capacity. Normally as well, you wouldn't have time and it wouldn't be ethical really to approach a family member or a friend. They may not even be at the hospital, they may be on site trying to get there. So they're not there, or B, they're in such a sort of state themselves, they can't really read and retain information or listen to what you're saying. So one of the most common models that's used now is emergency deferred consent. And obviously when you're writing your ethics application and your protocol, you have to be able to justify why you want to use an emergency deferred consent model in this population. So it is very stringently governed. It's not like you can just say, oh, we want to do it. So I think you've got that reassurance. What that basically means is you don't get consent from the participant because they're unable to consent. You don't get consent from a friend, relative, carer, whoever their consultee is, because they're either not at the hospital or it's not appropriate to discuss it with them. What you do is you get professional legal representative consent. Now, the person that tends to be, and which is almost what I would say the gold standard, is it should be a treating clinician who's involved in the patient's care, but they're completely independent of the trial. So they're nothing to do with the trial at all. So they've got no buy-in, there's no bias or anything like that, but they know the condition that you're treating. They've got a really good grounding in that clinical area, and they can make a decision for you. So that's what you would do. If you haven't got somebody who's willing to do that in that time frame, it could be that there's no one around that's willing to do that. You can use people completely independent as well. So it's always a good idea to kind of go, all right, we're recruiting in the ED, we might have this number of consultants. I'd also say get on board your nurse consultants, your advanced nurse practitioners, they can do these sort of things for you. You can ask somebody completely independent. So, for example, if it was a trauma trial, I'd say, can we get some of the trauma consultants who can do that as well? As long as they're not involved in the trial, you're good to go.
And are there any specific challenges you find with using that consent model, Jade?
Yeah, the biggest challenge is if you haven't talked to the group that you're going to ask to do that about the trial first. You can't just rock up to them when they're in the middle of treating a patient as well, particularly in a high pressure environment like an ED or a critical care, and say, oh, would you mind being the professional legal representative for this? So challenges that we've had before, previously when we first started using this model years ago, was they'd say, well, I don't even know what the trial's about. You're asking me to say yes on this participant's behalf. I don't even know what you're talking about. I trust you, but I don't know what you're on about. And I think that's completely fair enough, absolutely. Yeah. So I would say that's the biggest challenge, is making sure that before you start, everybody in that department who you may approach, and even ones that you might not, know that that's the model you're using and know why you're doing it. They don't just think you're willy-nilly popping patients into a trial.
Great, thank you. Rhys, what about you and the emergency department?
So yes, I think as Jade was saying, it's a similar thing really. As Jade was saying, if your team don't know what the trials are, then and that you might be approaching them for this, then it ends up being a challenge in the moment. By nature of an emergency deferred consent process, that it tends to be high pressure, tends to be emergency, and also we tend to be high pressured and we tend to be in that same emergency situation. And thus, if we don't take the time to be able to, in advance, prepare the department and the team to know what's coming up, then I think we're kind of failing at the first hurdle there. So that would be my kind of feedback on that.
And do you use any other consent models in the emergency department?
So we use a whole range of consent models. So Jade's talked about emergency deferred consent. We often use a similar kind of model of deferred consent. That is where we will, the patient is unable to consent for whatever reason. That might be a temporary lack of capacity from the condition that we're researching. And thus, instead of going to a professional, we might have the time to be able to go to that person's consultee, their personal consultee. So that can be their next of kin, that can be, partner, family, loved one, but it can also be a friend or a neighbour who they're incredibly close to, who, if Doris hasn't spoken to her son in 20 years, you maybe not want to call out of the blue saying, can your mum take part in a trial? Whereas if she sees her neighbour every single day, then that might be the person to talk to. And all that person is doing is agreeing that their loved one, the patient, can take part in a trial, and that they don't believe that that person would have any issues with taking part in the trial at that time. So if that person, say, was someone who distrusted healthcare, didn't like hospitals, and you want to put them in a trial where you're going to bring them back to hospital every month, they might not want to take part, and thus the trial might not be right for them. So it's about speaking to the relative, speaking to someone who knows the patient, who's able to act in their best interest at that time.
Great. And are there any key challenges that you find with doing that?
Yeah, the big challenge is that people feel quite overwhelmed to make that decision in that moment. We all know our loved ones quite well, but we might never have sat down with them and had a chat about whether they would like to take part in clinical research. So people often feel quite overwhelmed to make that decision in that moment. The way I adapt around that challenge is making sure, by definition, because it's not emergency deferred consent, you've got time to be able to go at that person's pace, making sure I'm providing them with information that's at an attainable level. Sometimes information sheets, even though they're in lay language, can be a bit difficult to attain. So making sure we're taking our time, explaining things in a way that they're able to go to, and making sure that they don't feel pressured by me pushing them to make a decision, that I'm just there to help guide them to the place that they want to go, or they need to go.
So let's think about data collection then involved with our research studies. So there's also challenges around the process of data collection in this setting. So as Rhys mentioned, there's big time pressures on staff due to well-recognised overcrowding and waiting times, and clinical staff are often not keen to have additional jobs added to their roles. There's also a lack of quiet space to chat to patients about patients or family members about a research study. Privacy may be needed for some of our studies if you're asking the patients for sensitive data. And then, as we've mentioned, patient cognition, or if this is impaired in any way, you might not be able to get things like baseline surveys completed, for example. Collecting data in an emergency setting can be very challenging for other reasons. And often the notes are half completed when you see the patient, or they might have disappeared to another department with the patient. They might have gone off to X-ray and the notes have gone with them. So even just that simple task of your normal record keeping can be more challenging than in other areas. Just trying to read a medic's handwriting can be problematic for a lot of us who work in that area. I mentioned database coding earlier. As a researcher with an interest in chest injuries, I've spent many hours in the last 20 years trying to ascertain whether a patient coded as chest actually refers to a heart attack or a chest injury. So it's little things like that that just add hours to your work if you don't address things properly at the point you write in your protocols. In terms of our interventions, finally, we need to consider the different types of interventions that are used in an emergency setting. So some interventions will focus on diagnostics. So you might be asking for a scan or a blood test. It could be an observational study. So you're collecting baseline data, for example, demographic data. You might be doing a qualitative study. So you need surveys or an interview completed. It might be an ethnological study, so you've actually got a researcher observing what is going on during your patient contact. And then obviously we've got drug or interventional trials or device trials. And the point I'm making is that all these different interventions need different skills and understanding by not just the research team members, but also the staff on the shop floor again. So it goes back to that point about needing really good education of our staff who are involved, the clinical staff. So I chatted to Jane about my one of my public research partners about her thoughts on this topic when I was first asked to do this webinar, and she wrote down some of her comments for me after we had chatted, as she'd gone away and thought about them. And some of the things that Jane said to me was, one of her first comments were that the principles of research with participants needs to be remembered. What she means is that research is done with the patient and not to the patient. So she went on to talk about the chief investigator of the trial in which she'd participated, and said he was so friendly and down to earth. I think if it hadn't been for him, then the experience might not have been so positive. And in general terms, she discussed the communication skills of the research team and said that it's really important that the research team talk to the patient and not over them or about them in front of them. This then creates an environment where you feel valued and not valuable. And I think that is such an important phrase when we're thinking about our research in any environment, but especially in an acute care setting or an emergency setting where patients don't always feel that we're giving them that level of care that we should because of the nature of the setting. She also said that in an emergency setting, it doesn't necessarily start with the researcher or the PI, the principal investigator. The experience leading up to that might affect the willingness to sign up. So we need to think about that very first contact we make with a patient in the emergency setting, because their experience leading up to the point of meeting us might not have been fantastic because of the nature of the overcrowding and everything else, and the environment, the busy environment. She said that the doctor-patient thing will always be there, but it's important to strike the right balance between professionalism and maintaining that relationship where the patient can talk, be heard and be listened to. She said that it was important as well for the PI or whoever's getting the patient to sign up to the study to understand the possible impact of that work and how the research could help future patients. So I think that patient perspective is really important to us when designing our research study, and to really think about what is important to the patient in an emergency setting. So then I talked to two principal investigators who'd worked on my ELECT 2 trial, which I finished recently, and that was a trial that looked at recruiting patients early on in the emergency setting or acute care setting who had chest injuries, and we were asking them to take part in an interventional trial where they would be doing an early exercise program, and we were looking at the impact on chronic pain at 3 months. So we needed to engage these patients at this point if they were going to complete our surveys at 3 months later. So I asked the girls what they found challenging, and I spoke to Sarah Davis from the Grange and Kate Jones, who works in the Heath, who were my PIs in those two places, and I asked what they found challenging about the trial. And they chatted about the challenges of learning, the process involved in setting up a trial. And one of the things they agreed with as principal investigators was the difficulty in getting the clinical leads approval for a trial. And especially in this setting, because the patients can be recruited in so many departments, so you need different clinical leads approving the study before you can even start. But let's have a listen to what they said about their other thoughts on getting patients recruited in this instance.
I did find that logistics were an issue within the emergency department because you'd often arrive and the waiting rooms were very chaotic. There were lots of people and family members everywhere, and then you'd have to try and call them in, and the patients are quite anxious because I think they felt that they might miss a doctor calling them or to be called for an intervention. So sometimes they found it quite hard to even leave the room. And then when you did leave the room, it was quite difficult to find space to take the patient. As you can imagine, the sort of A&E departments are quite busy, quite high stimulus areas, and there's not any space anywhere to speak with somebody to sort of conduct the interview. And I found that to be quite tricky at times.
What about actually knowing there was a patient in the department? Did you find that straightforward?
We've had difficulties with that in the past, trying to find out sort of which patients are on site, but I think we've developed better links recently with the pain team and the outreach teams, and they were very good. They had a contact number for me, and in fairness, they were contacting me regularly to let me know when there were any patients, and then vice versa, because we obviously interact with those quite a lot with this particular category of patients. So I think it was sort of helping each other, really.
Great, thank you. Anything you found, Kate?
Yeah, I think just picking up on that theme that Sarah said, kind of, but from more of a kind of patient overwhelm point of view, patients were often they struggled to take on the information that we were giving them, and they found it hard to work out how they were going to fit, if they had been picked to the intervention group, how they were going to fit that in around their injury. Was their pain relief going to be good enough in order for them to take part in the exercises? And a lot of them really struggled to kind of work out how a research trial was relevant to them at quite a stressful point in time. And I think that was particularly true with the more elderly population. So the more elderly population with more comorbidities, they kind of really struggled to deal with more than one issue at a time. So their predominant problem was that they had pain because they had lots of rib fractures, and they couldn't really contemplate thinking about anything bigger. So, you know, from a logistics point of view, there's kind of that high stimulus and anxiety, but also from a condition and pain point of view, that kind of overwhelm and anxiety played into the difficulties of getting them to think about the trial and think about consenting to it.
Did you find patients would, if they did consent, would they carry on with the trial then going forward?
Some of them did. What we did find was that a couple of people agreed, consented, and then withdrew because relatives were overwhelmed and anxious and didn't know how the trial would benefit them, what it would mean to them, and how it would fit in with their treatment. I think it's just a time of high anxiety for patients and their relatives. And then we're kind of asking them to do something that they're struggling to comprehend.
So in the next section, we're going to just look at what happens when we overcome some of these challenges and we actually get it right. So I asked one of my patient reps, Jane, who I mentioned earlier, who was a service user, and was recruited to a research trial, to start off by describing what happened to her. So she talks about the things that the girls were just talking about there in terms of the fear and anxiety. And then she goes on to talk about how the research team addressed some of these things and actually got these things right. So let's have a listen to what Jane said when I interviewed her. Off by telling me, Jane, about what actually happened to you on that the day when you had your accident, the first accident.
Yes, so I was out on a regular Saturday bike ride with my children. One was a little bit behind me and one was in front, and I was going down a hill on sort of a single lane road. I don't remember the accident, but essentially I was hit by a van. I don't remember anything until hospital about 2 days later, where I found that I'd got multiple skull fractures. I'd broken my humerus on one arm, my clavicle on the other side, got 9 rib fractures. They queried whether or not I'd fractured my sternum. I had a small pneumothorax, chipped one of my vertebrae, and I'd got an open fracture of my tib and fib.
Okay, and in terms of how you actually felt psychologically and cognitively at that point, can you describe that to us as well?
I suppose there's lots of things that go around. So being a parent, I didn't want my children, it was awful my children seeing me in that state, because you're mum and they don't want to see mum in hospital with black eyes and bruises and an external fixator and in a really bad way. Then there was work, and you're like, oh no, I'm going to be out of work for so long, and I've got loads to do. And then there's home issues, and we got a holiday booked, and then there was the thoughts about, was it my fault? Did I do something wrong? And of course I had no memory, so I'd got no idea whether any of that was down to me. And then it was, how long is it going to take to recover from this? How am I going to feel? Am I going to be leaving, walking out? Probably not. Am I going to need to be in a wheelchair? What's the long-term outcome and prognosis of this? So just lots and lots of things going around my head.
And I know you were recruited to a study during all of this. Can you tell me about that recruitment process that you went through?
Yeah, so the recruitment was actually down at Morriston. So I started at the Heath in Cardiff, but then because I needed plastic surgery, I had to go to Morriston. So a lady came to see me. She talked me all through it and what it would entail, because it would be about a year, but I was only going to need to go to Morriston perhaps about once every 3 months. That actually sounded okay. And although I was travelling from Cardiff to Swansea, that wasn't too bad a journey. I knew that work would actually be all right about it. And I just wanted to be able to help. In some ways, Morriston had been such a positive experience in terms of how well I'd been looked after. Just that ability to give something back. I didn't know if I was ever going to be able to, raise money by going out and doing a bike ride or a walk or something. So that this was something I could do, and it seemed a relatively straightforward project.
And was there anything you found particularly challenging about sort of given your consent or the intervention afterwards? Was there any sort of burden on you, did you feel, with signing up to such an intervention?
No, I mean, it was all explained well. I knew that I could withdraw if I wanted to, and the consent and the privacy was all explained to me. I knew the type of things that I was going to be asked to do. There'd be a questionnaire, which would either be sent to me in the post or emailed to me. So that was okay, you know, both quite straightforward. And I knew that what was going to happen when I went to Morriston was actually going to be very straightforward, and I'd be able to see both the plastic surgeons and the orthopaedic surgeons and consultants, as well as a physio, and that actually the questionnaires and then what they were going to ask me to do was going to be all, you know, quite straightforward, and nothing that I was going to get unduly anxious about.
Great, thank you, Jane. And logistically, getting back and forth to hospital, especially after your accident and things like that, was all that challenging, or did you manage that okay as well?
I think maybe the first time I had somebody take me, but certainly for the latter ones, I was able to drive. And even if I'd have had to have follow-up appointments actually at Morriston anyway for the plastic surgery. So it wasn't like I had to go additionally, because rather than going to the plastic surgery appointments, I just went to the research appointments. So I wasn't doubling up on anything. They were really pragmatic about that and just said, look, we'll just see you the once. So yeah, so that worked out fine.
Brilliant, thank you, Jane. So you can see from what Jane was saying there's things we need to consider when designing a study, and this is why the inclusion of public research partners is so important to us as researchers. So if we get it right by using the advice and the feedback from our research partners, we can hear from what Jane said about how the design controls for all the potential challenges we've talked about. So it might be delayed recruitment, it might be giving information and then going back and reinforcing that information once the patient's cognitive status has improved. Knowing that the patient is going to be kept in for a few days post-operatively gives us that opportunity to do that, for example. So it's about giving information in a timely and thorough manner. Also potentially harnessing the patient's desire to give back, because that will be important to a lot of people. Also, the patient's view that being involved in a research study would provide them with reassurance and support after discharge, which may not always be easily accessible to patients if they're not involved in a research study, so they don't get that follow-up contact that they would get otherwise. Timing follow-up trial work with clinic appointment then also reduces patient burden, as Jane described, in terms of getting back and forth to Swansea from where she lived in Cardiff. And that in turn will reduce the attrition and the loss to follow-up, the high rates of those that we talked about in an earlier slide. So to finish off, some key messages just to reinforce that have come out of this work with the 3 different groups of people that I interviewed. So keeping the research protocol pragmatic is really key in an emergency medicine setting. Teamwork, so not just between the research team itself, but also with the clinicians who work on the shop floor. These are the people who very much are going to make or break our research studies. The same with the patients as well. Education is key, and it's not just about educating one group of people, it's about educating in a rolling programme, so that we know that our emergency care staff or any medical staff really, and AHP staff will rotate regularly. So it's about ensuring our education is of a rolling nature, or is accessible, recorded, for example, where people can access it as they join the team. And then the most important thing of all, I think, is making sure that we include our public research partners from the outset. Don't include them late on once the study's designed, but get them involved from the very first moment you start formulating your research ideas. Because they're the people that will make sure that that research really works once it starts.